before you institute any topical or conservative management for OSSN. There are various regimes which are available. Commonly used drugs are MMC, interferon, and 5-FU. MMC has a little bit of more side effects. That way, interferon is much more gentle. And 5-FU has now been found to be much equally effective as MMC with lesser side effects. So whatever protocol you choose, there are many protocols, but you have to ensure that these are non-invasive tumors and localized to the epithelium. For invasive tumors like this lady who has this massive OSSN, you have done an excision, but the sclera is involved, it is positive. So you can go for a plug brachytherapy for the residual disease and try to salvage the eye, like done for this patient. For other cancers which are already gone into the eye, like intraocular invasion where there is an uveal prolapse already, there is no other modality but to go for an extended enucleation. Moving on to retinal blastoma, intraarterial chemotherapy is now the talk of the town because it has shown very good results, especially in recalcitrant or recurrent tumors which are resistant to other modes of therapy. There are very specific indications of the eye which are suitable. Once you select the suitable eyes, at least in our study, we have found 55% eye salvage rates for tumor which are resistant to other modes of therapy. For the cost constraint, we are now restricting ourselves to only to secondary tumors which are failed other therapies, but it has also shown very good results in primary treatment for advanced intraocular retinal blastoma, group C and group D tumors. Intravitreal therapy is another modality now in an armamentarium, which has now been extensively used for management of vitreous seeds and has given very good results in salvaging those eyes which otherwise would have undergone enucleation. Earlier, melphalan used to be the drug. Now with topotecan, these are much more safer, especially in Indian eyes where melphalan causes a lot of toxicity because of the pigmentation of the PE. You can also go for an intracameral chemotherapy for anterior segment seeding. These are the tumors which earlier used to be again enucleated, but a selected group of this tumor where there are just isolated seeds without any invasion of the iris or the ciliary body, you can go for intracameral chemotherapy along with other modalities like ISC or IVC or a plaque brachytherapy. Plaque is another modality which is very useful if you have it, especially for tumors which are resistant after chemo reduction where you have done the chemo, but the tumor has localized but not responding further, especially the well-differentiated tumor. They respond very well to plaque. This child had a residual tumor in one of the quadrants. This was post about 8 cycles of chemo reduction, and we just did a plaque to the residual tumor and it responded very well, and it's almost a flat scar at about 6 or I think 7 months of follow-up. Just last bit, important thing to know for retinal blastoma is the genetics, because this is an important aspect now in the management. If you see this child and 2-month-old child presented with a group E unilateral retinal blastoma, and we know that group E unilateral retinal blastoma is a 2-month-old child is not normal. Normally unilateral tumor happens in older children which are the sporadic. This is very likely to be germline, but the other eye is fine. So unless and until we know the germline status of the child, we cannot follow up this child. This child has to undergo maybe unnecessary UA if it is not germline. So we got a genetic testing done. We found a mutation. The child was germline. We followed up the child. 3 months down the line, there was another small tumor which came up in the other eye. We could immediately catch it at a very small state and treat it before it has gone to extensive site. I think I'll skip this bit. Liquid biopsy, another thing which is coming up in a big way, at least for the management of retinal blastoma, where you can detect circulating DNA and get the same information which we get from the tumor DNA without doing enucleation of the eye. So this is a lot of potential for prognostication as well as for developing newer targeted treatment therapy. And I'm sure in the next couple of years, we are going to hear more of it with time. So this is what I had to say. This is my whole team. I acknowledge the whole team who contribute every day in treatment of the ocular tumors that we see. Thank you so much.
That's a nice presentation, Dr. Sima. I think because of lack of time, I think you have to skip so many slides, and also we would be run through the slides. That's one of the wonderful presentation. In fact, your videos are really fantastic.